Blount disease, and it's probably one of the most published topics in pediatric orthopedics, and we still have a lot of questions and a lot of problems to solve. First of all, there's quite a few challenges. There's at least 2 different diseases, infantile Blounts and adolescent, or it's actually maybe even 4. Someone talks about juvenile Blount. In my opinion, probably just later discovered infantile Blounts. They're usually same and look same, and view just maybe a little bit less deformity, maybe because they have less time to develop. But there's a new interesting thing called slipped proximal tibial epiphysis. And there's actually Anish, he's not here, who was the first one who published on this. He was the first one to pay attention. So that's something can be completely different disease, where you can see completely normal joint line without plateau depression, but it looks very similar to slip capital epiphysis on the femoral head, like it was sliding around. We'll talk about it a little bit more, but I encourage you to take a look, for those of you who are treating Blounts, take a look what you have in your patients and see how many of them actually don't look like typical Blount. And this is the publication. I will give you the link later on it so you can read more about this. But I think it's a very, very interesting new topic in the field of Blounts. There is another challenge. We still don't know what caused it. There is different ideas, different things. Some of them are all fat target and overweight children. But it appears in the very slim and tiny ones with the same frequency. So excessive pressure might lead to some of the pathologies. Maybe it's a key role in adolescent Blounts, but we don't know for sure. Also, it's a very complicated 3-dimensional deformity. There is a varus of tibia, there is medial plateau depression in some of them, there is internal torsion, there is procurvatum. So, and it can complicate it by some additional deformities, like distal femoral deformity, which can be in different direction, depending on the infantile patient or its adolescent, or this distal femoral or distal tibial deformity. Some of them sound to be compensatory deformities. Some, that's difficult to understand where they are. But anyway, whenever you do, the goals of treatment are still the same. You want to correct the deformities. The question, though, comes, do we correct it to the straight mechanical axis? Do we overcorrect? Do we make it undercorrection, especially if you imagine what I call Texas-sized patients? Those are patients, some of them, being not skeletally mature, weigh twice as me, and I'm not a light person, so as you can imagine. And for them, if you make straight mechanical axis, you will see huge valgus, but it's not real valgus. This is the femoral fat, which is slipping down to the proximal tibia. You need to equalize leg length. And again, majority of cases, do you need to do it if it's just few centimeters? You definitely want to take care about the pain and prevent osteoarthritis. And like in any treatment, especially with external fixation, you need to manage complications because they will be there. So what's important? I was tasked to tell you what's important in the treatment of Blount disease, and I can finish all the presentation with just one word, planning. So if anything you need to know about what's important, that will answer your question. And your planning starts with treatment strategy, which is very important. Depending on age of patient, your strategy can be completely different, and surgical intervention will be different. Size of patient, again, as I told you, some of the Texas-sized patients, again, approaches can be different, and some things you can do in smaller, slimmer patients, you cannot do really in a big one. Severity of deformity and previous treatments. In Scottish Rite, we actually, especially my unit, which is called Center for Excellence in Limb Length and Reconstruction, majority of our patients are recurrent Blounts, and majority is secondary deformities, often iatrogenic deformities. And of course, psychology, peer, and family support is extremely important. And surgeon's comfort. You want to do the technique which you're most comfortable to perform, and not try to do something you don't know. But you always have friends, you always have colleagues. You know, you can easily get emails of all the faculties here, and I'm pretty sure you're all happy to answer your questions. So your treatment choices and your strategy are really varied, starting from very simple observation. This is actually a very good treatment choice too, because your observation, it doesn't mean you just send patient away and tell come and view. You explain what's going on, you set the expectations, and you pick the best time for what treatment you decide to do. I'm not talking about bracing. I don't think bracing is really efficient. It's maybe just temporary solution for maybe to relieve some pain, but I don't know. I don't believe it. Of course, there is growth modulation, and then you go to the more aggressive treatment like bar resection, plateau elevations, and different osteotomy. And it also complicates your strategy when you decide to do multi-level correction. Remember this compensatory or additional deformities, whatever you call it, on the femur. It can be varus or valgus, again, depending on age of patient. And you can do the stage correction. So let's look at some of those. Again, it's just a brief review, and we'll go in more detail with James' presentation and later on showing the case. Growth modulation, that's not only tension band plating. Let's start with hemiepiphysedesis, but then you need to be sure, of course, there is some growth remaining. There's a growth plate present, and there is something to do the growth with. But there's also another thing. Sometimes we put the 8 plate or whatever tension band plate not to correct deformity, but just stop progression until we can get more favorable time to do something more difficult. And if you will go back to adolescent Blounts, this is publication from our institutions, and it's 66% of them, according to patients they review in Scottish Rite Hospital, fail lateral hemiepiphysedesis. And it's not surprising because this is usually later developed disease and not so much growth left. And not surprisingly, the failure associated with age, more than 14. Again, for the boys, it's basically less than 2 years of growth left to whatever. For girls, it may be a little more. Sorry, for girls, it's done completely. Now, high bone mass index, and of course, in moderate to severe varus, the bigger the deformity is there. So greater deformity, not surprising to do. There is one specific for growth modulation with tension band plates in Blount disease. The force somehow breaks majority of the plates. You don't hear or don't see so much of breakage of A plate, H plate, O plate, whatever you use, that you can see in patient with Blount. You can see, like in the top left image, there's one plate was used, and what I suggest not to use in Blount's patients with a plate, don't use cannulated screws. There is no reason. Most of them are associated with breakage, and this was original release of 8 plate, and the company learned so fast and it reacted a little bit slower, but learned fast that breakage screws are very often there. So in Blount disease, just don't use them. The technique is pretty simple. You don't need cannulated screws. But there are some situations, like on the right lower image, you can see there was at least 3 different attempts of plates, and it still breaks. Recently, we done a little study there. So what plates are actually break less and get more successful. So first of all, one of the most often complications, surprisingly, was undercorrection, either because it was done late or technique was not, so plate was not working. Second was the breakage of the screws. And the only moderate breakage was achieved by using plate with 4 screws. And of course, age more than 13 years old. It's almost best predictor for the breakage, and deformity magnitude, which is not surprising. Another technique which we love a lot and use in Scottish Rite is physial bar resection. So that's, again, usually you suggestion to do it in a Langhus code 3 or more, and more favorable outcomes in children before age 7, especially if they not had previous surgeries. But we often combine bar resection with the other techniques, with growth modulation or high tibial osteotomy. Plateau elevation, it's suggested that it's indicated in selected children 7 years or older with knee instability due to medial plateau depression and often combined with osteotomy. I will not talk much about it because we don't do it. I don't recognize the necessity of it. I'll give you one little example. So this is, for example, 4-year-old female with moderate knee instability. Anyone would do plateau elevation on this patient? James, would you do any plateau? Say again? Guided growth, yeah. We actually went with high tibial osteotomy. Unfortunately, there were some complications with a little pin infection, but it went pretty smoothly. And this is 2 years older. So you can see if you align biomechanical axis in a younger patient, very often the joint surface actually restoring not so bad. And that's final X-ray we heard 14 years of old. We have to do a little bit of correction of deformity because overcorrection actually goes to opposite. So I don't think it's indicated in the majority of patients. So proximal tibial osteotomy, again, it depends, again, what patient you are treating. So you can do acute correction and fix it with pins, cast, or plate. You can do acute correction and use plate, which is, I would say, my least favorable option to do it. And of course, there's ability to use gradual correction. And you can use traditional Elizarov type frame with hinges. I call it crazy way, because with hinges, you have to be crazy precise and put in your hinge. Because if you're not in correct position, you will not correct the deformity, you create secondary deformity, you create translation. And of course, my favorite toy is the hexapod frames, because they allow you this parallel correction of all components of deformity, or you can stage it in different ways, just providing different prescription for the patient in different stages. So in early infantile Blounts, we like to do the high tibial osteotomy, again, depending on what's the stage they are, and just fixation with 2 pins and the cast. This was done on 4-year-old patient, and in majority of cases, you have correction, but the rate of recurrence is extremely high. And either you come back later and do the gross modulation, you combine it with bar resection, or you end up with something like that when the patient continues to grow and your corrective osteotomy grow out away of the physis, and then you have to do something really, really crazy in terms of correction of deformity in 2, sometimes even 3 levels. The plates, I really, as I told you, not big fan. So you can do acute correction, but some centers published about prophylactic fasciotomy, insertion of the dray, and you have to really care about them. And soft tissues, especially again in our situation, when you have patients like that, I don't think it's really a good idea to go through this amount of soft tissues, put in plate then. And what's reported complications are compartment syndrome, deep infection, non-unions, and so forth. And full restoration of mechanical axis is actually pretty difficult to align in surgery. And I will give you a little example why I personally don't like plates. And I like to cite my favorite words from one of my great partners, John Birch. We're all prisoners of our experience. And this is one of these reasons we don't like to do it. So that was lateral closing wedge tibial osteotomy, plate position there. Looks like alignment is okay, not perfect. And then this is 22 months later. And it didn't happen immediately, but you can imagine the amount of deformity there. So we have to go plan the correction. We use the frame. We use the circular frame, but that was quite difficult surgery. We have to remove the plate. Line, as you can see, the size of the rings is pretty big for this patient, and we were able to achieve the result. And of course, of my favorite approach is gradual correction. You can do it with the hinges. Again, you have to be precise in placing the hinges of the hexapod. Now, even though I love this approach, it's still the last option. This is quite uncomfortable procedure for the patient. This is technically challenging procedure. Not that osteotomy is not technically challenging, but here, that's as patients don't like it, and usually need to have and prepare them to go into the frame. Otherwise, you get this symptoms of what we call the cage rage. Doctor, take it out, whatever does it mean. So learning curve and complications are there. But we're dealing with very often with severe and recurrent deformities, secondary iatrogenic deformities, which are done either by not following the technique or just result the recurrence, scars, and obese patient. So patient like that size patient, they are, especially if they require lengthening, they ideal for the application of frame, because it also allows you to do the assessment and weight bearing. That one of the goals, and probably main goal, to use X-Fix on the patient to be sure they weight bear. And you can also fine-tune your correction of deformity, or if you need to do multi-level deformity, I honestly prefer the frame. We actually, about 10 years ago, we analyzed our experience a little bit with the patients we used with circular fixator with hinges. There were 45 patients treated, and diamond frame was not so bad. It's slightly bigger for the patient in adolescent population than infantile, and they obviously go longer on fixation, they're older and take longer time to heal. And hex support external fixation, there are different one of them, but they're ideal for situation in multi-planar deformity correction. And again, the key point here is planning, and we like to use the software to pre-build the frame. You use this frame as a template, and this is just a little illustration on this particular 14-year-old male with adolescent Blount disease. So this is our planning. You download, calibrate your X-rays. You take just 2 lines, play with these lines, align them with the fragment axis. This is actually not that simple and not discussable. How you align the joint line? Do you align it with the tibial plateau? Do you align it with femoral condyle? So there is still, I believe, I like to tell that this is where the deformity correction is still more art than it is science. And then software will actually point you to the apex of deformity, and this is where software put the virtual hinge. That's the beauty of hex support frame. This hinge is still there. And when you enter your rotational deformity, the software put the axis of rotational hinge and combination of your APN, lateral projection hinges axis. And then you can preview the correction. You see the frame, you optimize your frame. Software allows you to play with the rings, so you can select the minimum strut changes. Then you print your preoperative planning. This is one first printout I take to surgery. Then I take the second printout with strut sizes, and then you pre-build the frame. You can see the size of the frame. You can see my hands there. Apply it to the patient, but you have to go back after preoperative planning and adjust your mounting parameter. But software allows you to do adjustment, even if your X-rays are far, far from perfect. Like you can see in this particular case, you can see that proximal ring, it's almost like you're looking through it. And that's software allows to align it, get your mounting parameter, continue with the correction. And even such a big patient with such huge frames, they're still doing full weight bearing, or at least we're trying to do that. And at the frame removal, you can see we align this patient to the very good mechanical axis. But still, you can see that there is impression of valgus, even it's not there. So, as I said, what's important, this is planning. Now I want to give you a couple bonuses to this talk. The first one, remember I talked to you about the slip proximal tibial epiphysis. This is a new thing, and I suggested there's links of 2 articles, one of them from Anish. He was the first one to publish it. And second one I also strongly recommend. This is from Pete Murray from South Africa. He is the one who suggested transfascial osteotomy, basically sliding back. It's kind of like you fix the slip capital epiphysis with the pin. He also gives them very nice treatment algorithm. Also, I encourage you, start looking in your cases. And I have even one weird idea. Maybe some, if not all, of adolescent Blounts are actually kind of cohort of some kind of sleep proximal tibial epiphysis. And this is another one. This came from our institution. This is modified classification of infantile TBR. Very simple classification, A, B, and C, where in A, you can see a little bit of ossification of medial plateau. In B, your medial plateau is not ossified, but it looks like a cup which holds water. And in C, it's basically cup which is spilling the water. Very nice one, and I suggest to do it. It's a very good predictor about outcome. It doesn't really help much in treatment, but it helps you to explain in the patients what to expect. And of course, I invite all of you to visit Scottish Rite Hospital. In the next year, we have 2 different courses, one for residents and fellows and one high-end discussion quiz about controversies. Thank you very much.